Okay. Hello, everyone. Thank you so much for joining. I am Bracha Banian, family nurse practitioner and CEO of Ivy Drips. And today I have Dr. Messer. I'm really, really excited to have her on board doing this webinar, answering questions for us. She is a double board certified endocrinologist. She has practice in New York City as well as Connecticut and multiple other locations. She has been practicing for over 19 years and has been prescribing GLP-1s since 2006. So GLP-1s, Ozempic, Mounjaro, Tirzepatide is not new to her. She knows these medications really, really well. And I am really happy to be just talking about GLP-1s tonight and debunking myths, talking about side effects, things we should know about it, and outside use cases outside of weight loss. So I'm really happy to be doing this because I love talking about it, and I love talking to other people who love using this drug to help people. So thank you for your time.
Thanks for having me.
So my first topics that I wanted to talk about was, I'm just going to jump into it, like side effects that, let's say, or myths that people are concerns that people have, and say, is it a side effect? Is it something that we need to debunk, or is it something that we should be worried about? For everyone that's joining, you are welcome to ask questions just on the chat. You could do it as anonymous or not, and we will answer your questions throughout the webinar. So the first topic I'm going to talk about is thyroid cancer, because thyroid cancer is a really, really big concern for a lot of patients. And let's talk about thyroid cancer. Is it a concern for patients? What are, there are some, I know there's some studies on it. There are some controversial topics about thyroid cancer, and what is your take on it?
Well, I always say to my patients, you should be very concerned about thyroid cancer if you're a rodent. Otherwise, probably not so much. So not every animal model is really a great animal model to use. And this is one of those examples. So in the clinical trials, we saw an increased risk of medullary thyroid cancer in a dose and duration dependent fashion, but in rodents only. Unfortunately, rodents often meet their demise from this rare type of thyroid cancer called medullary thyroid cancer. Humans very rarely get thyroid cancer, and we have not seen, very rarely get medullary thyroid cancer, and we have not seen an uptick in cases since 2006 when these medications first came out. So a common misconception is that if you've had any type of thyroid cancer, that you cannot take these medications, that they're contraindicated, and that's absolutely not true. The only contraindications would be if A, you have a personal history of medullary thyroid cancer, which I've seen it once in the past 20 years, or B, you have some sort of genetic syndrome that predisposes you to it. But short of that, which is pretty much everybody, there are no contraindications.
Okay, so unless you have a family history of medullary thyroid cancer, then it's not applicable for you.
Or you have something called multiple endocrine neoplasia 2, which is a rare syndrome, MEN2, that predisposes to medullary thyroid cancer. Obviously, if you have a personal history of medullary thyroid cancer, you wouldn't be taking these medications. But yes, just taking a step back, there are so many different types of thyroid cancer. There's papillary, anaplastic, hopefully nobody has that, follicular. As long as you don't have medullary, which almost nobody has, you're fine. You can take these medications.
Okay, and if someone has a family history of any other cancers, then it's something that there's no risk for them for taking these medications.
When you say any other cancers, you mean any other types of thyroid cancer?
Thyroid, yeah, I'm talking about thyroid.
Yeah, absolutely, no risk.
Yeah.
Yeah, I would say
Okay.
most commonly, I'm in with a patient, and the patient's usually like a lawyer, and they're like, well, my clients think I'm a rodent. Like they always make that joke. And I'm like, that's really funny, but no, you can take this medication. No, the answer is you can really take it.
Okay. So that's great news. I think that is like a concern for a lot of people. And I think that maybe people are looking at their, I'm potentially thinking that people are probably looking at their thyroid a little bit more when they're on these medications if they're nervous about it. So, or worried about nodules, things like that. So I know that's like a big concern for a lot of patients, and I'm happy to hear that we're not using this study, particularly this, because sometimes we do use studies for mice to make certain conclusions, but for this one, it's not the case. Another big topic that has been going around TikTok about this TikTok singer has been saying she has osteoporosis, and I wanted to talk about that. What I've noticed, there are certain things that you'll get from taking medications, like the side effects, and there's, regardless whether it's Ozempic or another medication, it's just side effects. And there are certain times it's like when you don't use the drug properly, you get certain side effects. And so I want to talk about your opinion on bone loss and taking GLP-1s for osteoporosis
Well,
or
GLP-1s certainly will increase the risk of bone loss because anything that causes effective weight loss is going to increase the risk of bone loss. So I always say it's like astronauts. Astronauts used to always get osteoporosis because there was no weight bearing, right? There's no gravity. And now when an astronaut does go to outer space, they're treated prophylactically with a medication to prevent bone loss. So a very, very thin woman is like an astronaut. There is much less, force of gravity on her. Osteoporosis is a thin woman's condition. When you're heavy, every step you take, the bone thinks it's being injured and it builds new bone. So, that extra weight stimulates what's called osteoblastic activity. It's the cells that build bone. And so, yeah, of course, if you go from being obese to being a normal body mass index or even a low body mass index, you're going to have an increased risk of osteoporosis. The question is, would we not lose weight because of that fear? I don't think the answer is yes, right? So you're trading one condition for another, but you're also trading the risk of heart disease and diabetes and, a million other conditions for a potential risk of bone loss. And it's easy to treat bones. The endocrinologist who's giving you your weight loss medication likely will also treat your bones.
So is it the medication itself, or is it like the
Yeah.
fact of just losing the weight, right? Okay.
Like everything with these medications, or almost everything, it's not the medication. And I'm sure we're going to talk about Ozempic face and muscle loss, and we'll get into the same principle that weight loss comes with certain properties, which
Yeah.
includes loss of subcutaneous fat, which includes loss of muscle, and it includes potential bone loss. But these are not reasons to shy away from the medication.
Right.
And there are plenty of studies to show that if you lose weight from calorie restriction or if you lose weight from other weight loss medications, you'll see the exact same effects. So it's not unique to this class of medication.
Is there any side effect that comes particularly, so it's probably the same answer when we'll talk about it with muscle loss and thinning of the hair and all those things. Is there any side effect that GLP-1s cause that if someone lost weight without the medication or with a different medication, they won't get, but they'll get it if they'll use GLP-1s?
No, the only side effects are these non-catastrophic side effects. Like, yes,
Yeah,
certainly we do see increased risk of constipation and nausea
yeah,
and burping
yeah,
and,
yeah,
reflux. That's all GLP-1 mediated, of course.
yeah,
But no, these catastrophic side effects making their rounds on social media, absolutely not.
yeah. Just due to the fact that when you lose weight, you need to factor in other things, which people are not.
Correct.
So, okay, so we spoke about osteoporosis, osteopenia. I'm just going to jump into someone's question here. They wrote, um, is there a node in the thyroid gland? Okay, if they have a node in their thyroid gland, isn't that a contraindication? So it basically what we just spoke about before, that it's not.
Yeah, right. We would call it a nodule. If it looks like it's medullary, which is, again, almost so rare that I've never seen one. It has a very particular appearance. It would be very dark and it would be in the top half of the thyroid on either side. And obviously then we would need to biopsy it. But short of that, short of having a medullary thyroid cancer, there are no contraindications either with hyperthyroidism, hypothyroidism, which is too much thyroid hormone, too little, any type of nodule, any type of thyroid cancer. If it's not medullary thyroid cancer, it's not a contraindication. And
Yeah,
the FDA is really clear about this. They say you do not need to do serial thyroid ultrasounds while you're on this medication. Why do they say
yeah,
that? Because there's no increased risk of medullary in all of the
yeah,
studies,
yeah.
humans.
So we spoke about bone loss, spoke about thyroid cancer. Ozempic face, Ozempic butt, that's like another thing that people talk about. And to me, I also look at it as the same thing. It's just like when you lose weight too
Yeah.
quickly and
Yeah.
just in general when you're losing weight.
It's too quickly, and it's also at a certain age, right? Because we lose elasticity at a certain age. So maybe if you're in your 20s and you suddenly lose weight and you lose subcutaneous fat, maybe your skin will recover better. But, if you've been overweight for a while, you lose the weight quickly and you're of a certain age, you're definitely going to have a little bit of that sunken look. Thankfully, if you're really upset by it, we have fillers. It doesn't mean
Fillers.
that, if you were
Exactly.
very overweight, I want you to stay at that weight so that you don't have that complication.
Yeah. Yeah.
But yes, we see the
Uh,
exact same pattern with other modalities of weight loss.
yeah. Yeah. And the why I think it's such a hot topic is because so many people are losing weight through Ozempic more than ever before. And so that's why everyone's talking about all these
Yeah. They're all reasonable
different side
questions, but
effects. What?
all reasonable questions and concerns,
Yeah.
but they really do require studies, which have been done. And so that's why I'm so happy to be here tonight to actually talk about those studies. None
Yeah.
of this is opinion based.
Yeah. Okay, so we know that like nausea, bloating, gas, acid reflux is a side effect that people have, which I know a lot of people are concerned about. And we have different opinions in how we help people with this, but I'm curious to know your opinion on what to tell someone if they're feeling nauseous or having acid reflux. Um, I know a lot of people that are, when they're not monitored on these medications, they just take it. They feel so nauseous and so sick on it that they actually go off the medication because they're like, it's not worth it, which is sad because it's just like, unfortunately, they're not using it correctly. Like that shouldn't be that you shouldn't be sick on it the whole time. But I'd love your opinion on that.
I mean, there are some patients who really can't tolerate it. Like I'm going to say, even if they do everything perfectly, they can't tolerate it. Um, But there are definitely patients who get the severe nausea because they're not preventing constipation. So when you have a buildup of constipation, when you're not keeping track of your bowel movements, you're not following a high fiber diet, you're not making sure that you hydrate really well, you can get more nauseated over time. After a while, you can only have constipation build up so much, it literally like comes up to your diaphragm practically, and then the nausea begins. So that's number one, just making sure that you're having regular bowel movements. Also, of course, these medications make you full, but if you have a severe binge eating disorder, let's say, and you're not eating because of hunger, you're eating because of emotional concerns, you may overeat on these medications, and that's going to make you feel very sick. When patients have severe reflux, they're going to feel more nausea. And so, we always put people on that special diet to decrease the risk of reflux. So I think everybody knows this, maybe not. We try to eliminate alcohol and spicy food and caffeinated
Yeah.
foods and fatty foods and coffee. We try to have people not eat within 2 hours of bedtime because
Yeah.
eating so close to bedtime, the food hasn't been properly digested. Of course, you have the slowing of the passage of food through the gut. It's called gastroparesis. And so you're starting to see the food rise while you're sleeping and the acid's coming up, and that's creating nausea. So there's a lot that we can do in terms of changing the types of food that we're eating, changing the timing that we're eating, making sure we're hydrating, making sure we're having regular bowel movements. And honestly, I think having a little bit of prophylactic Zofran on hand is great. And if you're really in a
Yeah.
bind, calling on somebody like you to give IV fluids with Zofran, throw
Yeah.
that in there. But yeah, the vast majority of my patients do fine on it. I would also say, don't be too eager to have all the weight loss at once. Like it's okay to start on the lowest dose and stay there for months
Yeah.
until
Yeah.
you're fine, because eventually most people reach this equilibrium where they're not having the side effects. So nobody is telling you you have to go up on the dose every month. If you're taking
Yeah.
a stay on the 0.25, you won't lose weight
Correct.
that quickly, but you'll wait until you feel fine before going up on the dose. So that's probably
Yeah.
my best advice.
Yeah, yeah, I agree with that. I love that. I love staying low on the dose. Um, one more side effect, and have you seen it with cases of people who had like their GI tract went too slow and they had a bowel obstruction?
I have never seen bowel obstruction.
Okay,
Yeah, it would
cool.
be a pseudo obstruction if it's just from gastroparesis, right? It wouldn't be a real obstruction, but I've never seen it.
Okay, and prescribing this since 2006. Amazing.
Sorry,
Okay.
say it
Uh,
again.
I said, and you're doing this since 2006.
Oh yeah, so that's when the first of these
So,
medications came out. That was Byetta. Have you guys even, you probably don't even
yeah,
remember Byetta.
yeah. So, okay, couple of more questions here. Um, Another thing that people say a lot of times is, oh, we don't know the long-term studies on this. So we have a lot of studies on this. What is your like take when you hear people say, we don't know the long-term studies on this?
I start by saying, look, this is a naturally occurring hormone, right? So it's 97% identical to innate GLP-1. So let's just take a step back. You are taking a hormone when you're taking these injectables, right? So GLP-1 receptor agonists. So GLP-1s are these natural hormones in the gut produced by the small intestine. They have effects throughout the body in terms of satiety, in terms of lack of appetite, in terms of gastric motility. And so when these were first found in the Gila monster and they were isolated, the issue was that they were so short acting. And so scientists literally just changed 3 amino acids to make them longer acting. If you're really into naturopathy, which I'm not necessarily so into, but if you are, these are natural hormones, right? This is as bioidentical as you get. And then, so that would be almost all the hormones leading up to Zepbound, and then Zepbound slash Mounjaro, which are tirzepatide. They have two hormones, right? GIP and GLP-1, but still natural hormones. So it does make me feel good to know that we're just giving back something that's,
Yeah.
evolved for millions of
Naturally.
years in humans and is natural. So we'll start with that.
Yeah.
And then we do have 20 years of data at this point showing that every single side effect, if you want to call it that, is positive, right? So it's an anti-inflammatory. And I don't have to tell you the number of ways that we can use this. So
Yeah.
it's not just for weight and it's not just for diabetes. Obviously, now it's for sleep apnea, but soon, hopefully, it'll be for depression and OCD and anxiety and maybe schizophrenia and MS and Parkinson's and
Yeah.
Alzheimer's and rheumatoid arthritis. And I mean, the list goes on and on and on. I mean, humans are not supposed to be living in a chronic state of inflammation. So this is
Yeah.
by restoring insulin sensitivity, decreasing visceral fat, which is the fat around the organs, we are going back to a more natural state that occurred before we had all this processed food and before obesity was an epidemic.
Yeah. Yeah. I love that. Okay, so I have a lot of questions that, and this is a topic we wanted to talk about was, will I gain the weight back? So someone wrote here, what is negative besides coming off of it and not dieting well to gain all the weight back? So yeah, a lot of people again always think they go on the medication and you gain the weight back, which is case for a lot of people and case for not other people. What, in your opinion, is something that people could do to not gain the weight back? And yeah, what's your opinion about people gaining the weight back?
All right, well, this is why I set up a second practice just to address this issue. I'll start by saying that I think, I can't tell with 100% certainty, but I can mostly tell if a patient is going to gain the weight back or not. So patients who don't gain the weight back, they've gained it from, let's say, a round of IVF or pregnancy, or they went through a really hard time. Maybe they were mourning the loss of somebody close to them and, didn't leave the house for a few months and gained a lot of weight. These are patients who always had good habits and then something happened. Maybe they went on a medication that made them gain the weight. I'm like, this is fabulous. You'll take it for a few months and then you'll never need me again. The patients
Yeah,
who will almost inevitably gain back the weight if we really don't do a full court press with them are patients who have been struggling since childhood or who have emotional eating, deep-seated issues with food. And so
yeah,
those patients are set up for failure if you don't have a multi-specialty group addressing all of
okay,
the aspects of weight gain. And that's what I think
correct,
is lacking in all of these online programs, right? Like, yes, the
correct.
medication works if anybody gives it, but you really need to have a system in place of support and trying to figure out the underlying causes of the weight gain. So what do I mean by that? You need potentially a psychologist, cognitive behavioral therapy, um, and sometimes you need a health coach, right? Because sometimes we know exactly what we're doing, but we have issues with accountability. So all of these things are crucial beyond just the person who's prescribing the GLP-1 and helping patients.
Yeah. Ooh, I think you froze. I think you froze, or I froze, or someone froze.
Me, you froze, but anyway, we're back.
Okay. So basically what we're saying is that, like, when you're on these medications, it's not just about taking the medications. There's so many other components that need to happen. It's like, we do ketamine therapy also, and it's like the same thing. Like, you can use ketamine as, you're going to a party, you use it as a drug, and it's actually used really well for resistant depression. But it's like, there's so many other things happening when someone goes through the process of ketamine therapy. Are you with me? I'm losing Dr. Messer. Mm. Hi.
Hi,
Okay, we're back.
you're back.
So I think that's like a huge missing link in these medications, that they're so brilliant and amazing, but they're like not used correctly, and people are not using it with proper guidance. And like half of the medication is actually the proper guidance, because as you said, like, the medications are going to work,
Right.
but if you're not having the proper help and understanding how to use it, and again, as you said, like, emotional eating, and just having an entire multiple medical team with you, then you are likely going to gain the weight back.
Yeah. If you're not doing it's very easy to say to your patient, you have to start exercising. But what if you haven't diagnosed them with the sleep apnea, right? And they're exhausted. Like, that's legitimate. What if they're going through menopause and you're not treating them with the HRT, even though it's appropriate, and they're not sleeping and they're having mood changes? Like, all of these things need to be treated at the same time. Like, it can't just be in isolation. Here's your injection. See how you do. You
Yeah.
get 6 months of it. Good luck.
Yeah. It needs to be together with the team.
Yeah.
Okay. I want to talk about outside weight loss, but I want to answer a couple questions that came in. So someone said, I don't know what dosage to start, like, that I would start with to help lose weight and then keep my diet, etc. I would say, like, you don't need to have to know that. Like, that's why you need to go to someone who is going to help you. Like, it's not your responsibility to find out what dose you should go on by yourself. Like, it's the point that you have a conversation with the provider to help you do that. Like, I don't think it's not like, you go and you take Pepsid and you're taking 20 milligrams, or Advil, and you take, okay, I know I'm supposed to take 600 or 800. And so it would be something that you would, like, have to go through a proper assessment to know what dose you would take. And let me hear
To be
your
fair,
opinion.
we always start at the lowest dose. It doesn't matter who.
Okay, correct,
Yeah.
correct,
Yeah. So we
correct.
don't even really need to do an assessment to say we always start low and go slowly.
Right, but she was like, I don't know what doses to do to start losing weight. Right,
Oh,
correct. You're
to
always,
start losing weight. Oh, well, that's
and
different for
then keep
everybody.
my
So,
diet and things like that. Right, yeah.
right,
So
right.
yeah, for the most part, we always start at 0.25. I do have sometimes patients, actually, they don't tolerate 0.25. And so, like, we'll even go lower with them,
Yeah.
but
Yeah.
most people don't
Agreed.
even, but
Yeah.
not everyone.
Everyone has a
Everyone's
different
different.
maintenance dose, and that's discussion between you and the provider, figuring out what dose allows you to maintain your ideal body weight without giving you too many side effects. So there's no one set answer there.
Yeah. So someone skipped, she's like, okay, someone jumped in late, and she's had a question about, she has hypothyroidism and she's on Manjaro, and should she worry about that? You see your endocrinologist every 3 months. Well, As we said, Dr. Messer, who is an endocrinologist, and does this for a living, she, stated that there's actually no studies that are proven to really accept medullary thyroid cancer that we should ever be worried about. And hypothyroidism is not a contraindication to going on these medications. Okay, great question here. Why do I crave more sweets than I ever did on this medication, but completely stopped coffee and alcohol for 6 months since I started? I love this question. Okay, I'd love your opinion on it.
I mean, it's supposed to prevent cravings for sweets. I think sometimes when people have been so restrictive with themselves because their whole lives they gained weight so easily and now they're suddenly losing weight, they allow themselves to reintroduce things that they've forbidden themselves for so many years. So I've definitely seen that pattern, but that's the medication itself doesn't cause sweet cravings. It's probably
Yeah.
just what I mentioned.
Yeah, yeah. I've read that in a book, The Magic Pill, and he was saying that he was a journalist who wrote it. And he was saying that he also started craving sweets. But yes, definitely it's not from the medication. It does the opposite. It's interesting. Um, okay, so can you talk about the science as it pertains to being on a low dose of tirzepatide for weight maintenance and or losing 5 to 10 pounds and keeping it off? I'm asked about this by a lot of clients and friends.
I mean,
Okay.
there is no science because again, it's bespoke. Everybody's different, but I certainly have some patients who can take for tirzepatide, they can be on 3 milligrams or even microdosing like 1.5 milligrams and maintain the weight loss. But other patients require 15. So there is no science. They don't test these medications on microdoses or even on
Yeah,
starting doses. They test them on therapeutic doses. So there are no randomized controlled trials looking at that. But
yeah,
anecdotally, it works.
yeah. Microdosing, there's like no studies on I mean, the microdosing isn't something that there's studies on it yet. It's really just certain providers that are flexible and open to using these medications in off-label uses, which is why I love talking to you about this. Okay, this is another question that I was going to get into. I hope we have time to answer everyone's questions. A lot of questions here. Are you aware of the science on how these drugs affect menopausal cycle and perimenopausal? That was like another topic that I actually wanted to talk about outside of weight loss. And hormones. So let's just dive into this question: menopausal weight gain, and your opinion on using these medications for menopausal weight gains and the science behind it. I would love
So,
your opinion on that.
so just looking at the question, this is from Liz Zuckerberg, I think.
Yeah,
It's how the drugs affect menopausal menstrual cycles. So, which I think is a different question from how can they help combat the weight gain that we see during menopause? So I'll answer both questions. In terms of menstrual cycles, well, we clearly know that the weight loss and not the medication can improve or even cure polycystic ovary syndrome, which is a syndrome, not a disease. So it often goes away with weight loss. Um, we know that it improves fertility through the resumption of monthly cycles. There really is no effect on perimenopause or when you're going to enter perimenopause. That's just sort of genetically determined by egg quality and count and things like that. But we do know that in the 10 years after menopause begins, most people gain about 10 pounds. And there's so many theories on this. Um, when the estrogen drops, we see an increase in insulin resistance. Insulin resistance, not a good thing because then your body overproduces insulin. Insulin is what we call an anabolic hormone. It leads to weight gain. So, the menopause may cause weight gain because of insulin resistance, but there are plenty of patients gaining the weight without the insulin resistance. So that obviously doesn't completely answer the question. When
yeah,
estrogen goes down, there's a pituitary hormone that skyrockets. It's called FSH, and that hormone has been implicated in many studies. In weight gain. So it may be due to that. But regardless, we know that giving the estrogen back, unfortunately, does not lead to improvement in weight. It does, however, sort of change the distribution of weight. So, a lot of that weight is central, and taking estrogen may help keep you from depositing that visceral fat, but it's not going to lead to weight loss. And so I'm very quick in perimenopause to prescribe the GLP-1s because I feel like we're getting tortured enough, right? You have hot flashes, you're not sleeping, your mood's changing.
yeah.
One thing I can do is help with weight loss. And also because we know that as estrogen goes down, the LDL, which is the bad cholesterol, goes up. So potentially increased cardiovascular risk. So I like to give something with this really incredible
Yeah.
decreased cardiovascular risk. I hope that answered the question.
So, yeah, I believe so. What are your thoughts on just, like, which drugs do you, I mean, which drugs do you like for menopausal and just in general? Yeah.
Um, do we mean which weight loss drugs or
Yeah,
which
yeah. Do
hormone
you have a
replacement
particular
therapy?
drug that, yeah, which GLP
Uh,
ones like do you have a
well,
particular
I
one
almost
that's
never
better?
prescribe Ozempic. So let me just take a step back. Maybe everybody knows this already, but semaglutide, which is the generic form of Ozempic and Wegovy. Ozempic is the diabetes form of it, and Wegovy is the weight loss form. Tirzepatide, which is the dual agonist medication, it's GLP-1 and GIP, is either called Mounjaro if we're talking about diabetes, or Zepbound if we're talking about weight loss. And a triple agonist, we call it triple G, is coming out either later this year or in
Yeah.
2026. So I have a huge bias towards prescribing tirzepatide rather than semaglutide, and that's because in actually not so much in clinical trials, but in real life experience, many fewer side effects and almost double the weight loss in clinical trials. So whereas people usually lose about 15% of their body weight with semaglutide, they lose about 30% of their body weight at the highest
Yeah.
doses with tirzepatide. So I can get away with much lower doses with tirzepatide, which means fewer side effects and have the patient lose more weight. So I feel like even though Ozempic is more famous, I'm not using it very much. And plus, then you can say to your friends, no, I'm not on Ozempic.
Okay, I love that. Okay. I have, and I don't know, I guess for me, I have noticed that I don't know why I found semaglutide, Ozempic to help better with like impulse things, impulsive behaviors over tirzepatide, but I don't have an answer as to why I've seen that. I just seen that more like with binge, like with drinking alcohol or smoking, like some of which is interesting because
Yeah.
tirzepatide has both inside of them. So I don't have an answer for that. There's certain things that we just don't really know about this drug. Okay,
Yeah.
this is a great question. I've seen a couple of topics on it. Um, does tirzepatide affect your sex drive?
So tirzepatide doesn't directly affect sex drive, although, because so much of sex drive, at least with women, libido is emotional. When you're just feeling confident, when you're feeling better about yourself, sex drive increases. Um,
Yeah.
so that's in women. In men, potentially, but again, as an indirect effect, because as men gain weight, the testosterone levels drop. And that's probably, and along with that, the uh the sperm count drops. And so that's probably this evolutionary adaptation to say like, okay, you're a little heavy now to be running around after a toddler. And so we see that almost inevitably in men. This sudden drop in middle age of testosterone is really not due to middle age. It's due to weight gain because men who are thin and in good shape in middle age have sky high testosterone. So yes, as those men lose the weight, their testosterone does go up. And we start to see an increased sex drive, but the same is not the same. We don't see that with women.
But as they lose weight, and let's say they're on tirzepatide and as they're losing weight, their sex drive is they're saying is decreasing.
Right. And I'm
Meaning,
saying it's the exact opposite. There is an effect on sex drive, but it's the opposite of what people are asking. The sex drive
yeah.
improves.
Oh, okay.
Yeah.
So, so you haven't seen it in your practice, I guess, that
I
people
mean,
are,
look, if you're vomiting and you're burping, like that's not going to do
yeah,
much for your libido, but no, I
but
do
you
not see it
have
sex
in
drive.
general. Okay.
Yeah.
Okay, so this is another question. So does it make sense that after being on tirzepatide 20 units weekly for 6 weeks, and the last 2 weeks, there hasn't been any weight loss at all while the same on diet? I'm actually not going to answer this question for multiple
So
reasons. I'm
I
going to
don't
go
know exactly what they mean by 20. I don't know what they mean by 20 units
the concentration would be,
because there are different concentrations with every
yeah,
compounding pharmacy. So that person, if they can just convert that to milligrams, because there's
I,
no standard.
yeah, I think it's probably like, about like 3.5.
Okay.
Yeah. So the question is, should he go up?
Well, 3.5 is a tiny, tiny dose. So if you're tolerating it, you'd want to ramp up the dose. Yeah.
Yeah.
But before, yeah, I would just double check whoever wrote that question, how many milligrams you're actually on. I don't want to give bad advice.
Yeah. Okay. Great question. Love it. Thanks for the comments. Um, I also crave sweets on this medication, but lost crave to alcohol. Um, so same comment as before. What would you recommend to someone who's craving those sweets? Increase their protein levels? What would you say to them who they're just starting to crave sweets on these
Um,
medications?
yeah, sometimes I'll combine it with naltrexone, which is an addiction medication. I usually give small doses, like 25 milligrams, and I'll give it 30 minutes or so before the cravings begin. Um, so that's one thing we can do. I always assess patients, make sure that there's no binge. If the patient has ADD, it's highly likely that there's also some binge eating tendencies. And sometimes I'll start Vyvanse for that binge eating. Um, and then obviously set my patient up with the cognitive behavioral therapist, try to figure out why they're having all these cravings and, do a little bit of a deeper dive into the underlying causes of the cravings
Okay.
because it's really not from the medication.
So is there something in their diet that they could change?
Well, I mean, usually when you really go cold turkey on sweets after a week or two, it gets easier and you stop
Yeah.
craving. But I wouldn't say that increasing protein, is really going to make much of a difference. Increasing fiber, increasing water, it's not really going to change anything.
Okay. Okay. I hope we'll be able to get to all the questions, but I don't know if we will. But let's just talk about microdosing for a quick minute and your thoughts on it. I love microdosing. I think it's so cool. And um, what is your thoughts on microdosing and what do you use microdosing for? Because I know we talked about this like before, but just like tell us a little bit about what are the different outside use cases you're using microdosing for.
Okay. My caveat being that none of this is evidence-based, even though I pride myself on being evidence-based. Um, so I use it when patients can't tolerate higher doses. I also use it for maintenance. So let's say a patient has lost the 15 pounds that they wanted to lose. Sometimes I'll pull back on the dose and see if the patient can maintain the weight loss. Um, just because there are so many fewer side effects, I figure let's give as little as possible. I sometimes have that point of view, not always. So yeah, I'll use it for maintenance of weight loss rather than initial weight loss properties. And then sometimes, and I really don't have any good data on whether it works as an anti-inflammatory at these low doses, but I have a lot of patients who maybe have a gene for Alzheimer's or strong family history of Alzheimer's, like they'll have an ApoE gene and they don't qualify for the monoclonal antibodies or there are too many side effects from those, right? There's like risk of brain bleed. And so they don't want to take them. So they're like, what can I do? And they're already really thin. I sometimes do microdosing of these medications to help reduce risk because I figure that there's nothing to lose and we don't really have time for the studies to be done in these patients who are at high risk for
Yeah.
Alzheimer's. So,
Yeah.
in those types of patients, I'll do microdosing.
Yeah, love that. Um, what are your thoughts on it for patients who have eating disorders, so anorexia and bulimia?
So I don't give it to anybody with active anorexia because of the risk
Okay.
of hypokalemia, low potassium. I love to give it to patients who have a history of anorexia because in a lot of those patients, the food noise never really disappears. And I think it's really instrumental in helping patients live normal day-to-day lives without thinking about food, without obsessing about their next meal
Yeah,
and,
yeah,
how many calories they ate. So that's wonderful. And certainly for binge eating, I love it.
yeah. For bulimia, for patients who are actively
Yeah,
purging,
paradoxically, it helps decrease bulimic episodes, right? Even though it causes nausea, because of course,
it's
we
so
know this
cool.
is right. When you think about the underlying way that it works, it makes sense that it helps with bulimia.
Yeah. We had a really great case where like 12 hours after we were taking care of a woman who 12 hours after her first injection, like for the first time ever, she was able to control her purging, which was like a really cool success story that like made us do it a little bit more because it's definitely a new topic.
It's a
And
topic.
so
Yeah, sometimes I have psychologists, outside psychologists saying, well, then, the patient can't put in the work if they're not feeling the pain. I'm kind of like, I don't want them to feel the pain. I'm sorry. Like you've tried now for the past 10 years, my turn.
yeah. And also, it's not like in isolation. Like I think people, for some reason, people look at it as the in isolation. It's just something that's like finally, it's like in conjunction. It's like conjunction therapy with
Yeah.
other
I guess
things.
they're saying that they can't really respond to therapy because they don't remember the feelings that they were having and how to work through them, which may be
Yeah.
true, but
I would think
uh,
the opposite now they're not being obsessed with food and they can think about other things potentially if they want to. So,
I mean, I agree
uh,
with you. Yeah, wholeheartedly agree with you.
yeah. Um, and what about addiction? What are your thoughts about this medication being used for addiction, smoking,
Yeah.
alcohol, even like drugs? Like, what are your thoughts on it? And do you put people on it to like curb smoking addiction?
I don't, but I can imagine it would work. I mean, it works with every other addiction, so why not? I just have so many great medications for smoking. I use so much Wellbutrin and Chantix, and there are enough other things that work. Um, but I certainly would. I would be happy to try it, but I haven't used it yet. I find that the tirzepatide is better for alcohol, but that's just anecdotal. Um,
Yeah,
and there've been a bunch of great trials looking at tirzepatide, but there are a bunch of great trials for semaglutide as well. Um,
yeah,
but yeah, for the addiction, it often works well in the beginning, and I feel like, wow, I'm like a wizard. And
yeah,
then and then it stops working as well, and then I have to sort of combine it with other medications to keep it working. There's definitely a little bit of recidivism.
yeah. And two questions I have here, and it's first of all, why do you think it like what is happening in our do we I mean I have some ideas, but I don't know, we don't like fully know what's happening in people's brain that it's affecting our reward system and why it's causing that. Like, do you have any just thoughts on that?
I mean, yes, we like know the circuitry, like we know what's happening in the mesolimbic system, we know what's happening with the POMC neurons, but like how, why exactly? Not really.
Yeah. Um, ADHD. I found using GLP-1s alone for patients who have severe ADHD, so sometimes it doesn't work as well. What are your thoughts on that? And I guess
Right.
you
I think
do
it's
combined
because of that.
therapy.
I think it's because, if you think about the underlying pathophysiology of ADHD, it's like they're a little bit low on dopamine. And so the binge eating goes so hand in hand with
Yeah,
ADHD because it gives them that dopamine hit that they're really lacking. And so that's why I don't even really try to treat with GLP-1s in an isolated fashion. I feel like they need to be on the stimulant to get their dopamine in order to really be successful. So yeah, very
yeah,
much a fan of using not just Vyvanse, but Vyvanse is the only one that's actually FDA approved for binge eating.
yeah.
So combining them
Works very much better combo. Yeah,
much better. Yeah.
yeah. Okay, so when you talk about microdosing, so this is a question that someone has. When you talk about microdosing, can it be done and spread over weeks, like taking it every 3 to 4 weeks rather than every week, and any data on that being effective? I mean, again, all of these things that we're saying about microdosing, it's really just like Dr. Messer is just saying things that she's done, and she's doing this since 2006 in terms of GLP-1s. And so I don't think there's any like studies on microdosing, but
No,
yeah,
I mean, the one thing I would say is I don't like increasing the interval between the doses if the dose is too high, because then you get really sick, right? So if somebody is on tirzepatide 15 milligrams, I'm not going to say, now let's try doing it every 2 weeks. Now let's try doing it once a month because they'll be violently ill. But if they're on, tiny doses, let's say they're on 2.5 milligrams, of course, have at it. You want to change the interval to every 10 to 14 days, stretch it as far as you want to see
yeah,
how if you can maintain the weight loss and maintain the absence of food noise, that's great. I never really go like above 5 milligrams. I'm pretty hesitant to start increasing the interval too much.
yeah. Slow and steady wins the race.
Agreed.
Um, okay, so, oh, what are your thoughts? I'm gonna read someone else's question and then we'll wrap up soon. First of all, what are your thoughts on migraines? Because I've had people say it helps them with migraines, and I had people say it causes migraines. So what are your thoughts on that?
I think both. So there are some studies to show that weight loss can help with migraines. There are other studies showing that decreasing inflammation can help with migraines, but also dehydration can worsen migraines. So I think
Yeah.
some of it's dietary, like if you're not eating enough, if you're not drinking enough, that can be a trigger. Everybody's so different. Sometimes alcohol brings it on, and now you're drinking less alcohol, so you feel better. Um, so I think it's patient dependent.
Yeah.
But net, I would say it's probably a decreased risk of migraines.
Yeah. Yeah. Um, I just actually want to take a minute to talk about pediatrics because that is like a topic that I sent all of our peds to you. We don't touch peds. What are your thoughts on um, children or pediatrics going
Yeah.
on these medications when they're suffering with obesity because it's like really complex and there's not a lot of people that do it. So if anyone does have anyone, especially pediatric suffering with obesity or just have questions, like Dr. Messer does this. But what are your thoughts on it, putting kids
Yeah.
on medication at a young age? Do you think the other side of people saying like causing long life issues, then they're always going to be relying on these medications?
So I'll start by saying, I'm sure the audience knows this, that it is FDA approved for 12 and up, right? So we can get it covered, which is a big deal. Wegovy only, not yet Zepbound, but I'm sure it's going to come. Um, so I would take the view that it can be super traumatic, not for everybody, but for a lot of teenagers going through middle school and high school, overweight, and that can lead to long-lasting insecurities. I would also say that at a young age, you can start developing real conditions. So this is not just about vanity. I mean, I had a patient, this was a different story. This was a million years ago. I sent for a sleeve gastrectomy. It was before we were really using the GLP-1s all the time. It was back when they were like very weak. And she already had early liver failure. She had
Oh,
cirrhosis
wow.
um, from from fatty liver, right? So she was maybe 16 years old. So we can really develop severe medical issues. You can get sleep apnea as a kid, you can get prediabetes, diabetes. And so I understand the point, like, oh, we don't want patients to be on these forever, but we also don't want for you to be developing heart disease and diabetes as a 16-year-old. So I think it makes for a much more pleasant, adolescent experience. And sometimes it's easier after high school to really focus on diet, exercise, like, there are conditions that during adolescence where it's a little bit harder. Um,
Yeah.
so yeah, I have no issue with it at all.
Yeah. Amazing. What do you think the future of these medications are? Do you think more and more people will be prescribing them for pretty much
Everything.
every condition?
I hope so. Yeah. So I think the future is we're going to be combining as many hormone agonists as possible, right? We have the glucagon receptor agonist coming out, but they're trying to figure out every hormone. I think to sort of like overcome the resistance that you may develop over time, we're now increasing every hormone simultaneously. Um,
Yeah.
but I also think, artificial intelligence is probably the key to developing different medications that have fewer side effects that can be given orally.
Yeah.
Just to be an example, at Harvard, they're testing like hundreds of millions of plants using AI to figure out if they're naturally occurring incretins, which are the GLP-1s, GIPs, et cetera.
Yeah.
Um, so that we can, and I don't mean like the silly, like, oh God, I can't even remember. What's the Kardashian supplement called? You know what I'm
Oh,
talking about?
yeah. I don't
Like,
know, but let's
I
talk
don't
about
mean
that
that, like
later.
fake GLP-1. I mean like real incretins in a more natural form. So I think that's the future of these medications. Hopefully they'll become more tolerable, they'll become cheaper. They did just announce today that the list price for Wegovy in the pharmacy with no insurance is $4.99, down from over 1,000. So that's today. So
Wow.
that's super exciting. I know that's not cheap,
Wow.
but if it's half the price, so it's something,
No.
something big.
Yeah.
Yeah, so they're going to become more affordable. They're going to go off
Yeah.
patent. Yeah.
Yeah. And maybe they'll be known for more popular than just for weight loss because weight loss is one of many things, but also as you lose weight, you experience so many other benefits, which I think people don't realize, like, that come along with obesity.
True.
So, cool. So just let's ask this question. Someone's asking, I'm on the same dose of semaglutide, 1.5 for a few weeks, but starting to feel nauseous more often. And I have trouble getting in enough protein. Do you recommend spacing out more? Example, every 2 weeks. You recommend spacing it out more. So
Yeah, I mean, I would really want to know why they're getting more nauseated, make sure they're not
yeah,
experiencing, because it's a little odd to have an uptick in nausea as time goes on. So I
yeah,
just want to make sure they're not getting constipated, they're not getting more reflux. But in
yeah.
the absence of all that, sure, why not space it out a little bit more?
Yeah. Or potentially go lower if she's not being able to put it in enough protein. Like if she's not able to eat enough, or potentially go lower, maybe. I don't know.
Sure.
More to discuss. Yeah. Um, okay, cool. Now last question for you. Is there any like recent studies that I know that you're always constantly on top of the research, but is there any like recent studies that you recently read that want to share or
Sure. Um, we didn't really touch on Nion, which is this belief that these medications can cause sudden blindness, which I got a
oh
million.
yes,
Yeah, I
yes,
got a
let's talk about that.
million
Thank
emails
you.
about when it was all over Wall Street Journal and New York Post, et cetera, sensationalism at its best. Um, so this was based on a trial that was at the Mass General Eye and Ear Institute. And so it was a small number of patients who all had underlying disease only in one setting. And they showed that there was a statistically significant increased risk of this rare eye condition called non-arteritic ischemic optic neuropathy, which is like a mouthful, but it basically means that the nerve that supplies blood to the eyes loses the blood flow. Um, and so everybody was like emailing me, should we go off these medications? So they just did in February of 2025, they just published online. It's not even in print yet, what's called a retrospective trial, which means they looked back at records of people who were taking these medications versus not taking the medication to see if there was any increased risk. And they control for every variable, weight, blood pressure, every other comorbidity, diabetes. So they looked at over 100 million people. So much better than
Yeah,
like the, small number of people they looked at the Mass General Eye Institute. And they found that there was absolutely no increased risk of blindness. And so there is never going to be a prospective study. It would be expensive and there's no reason, but we can stop worrying about blindness.
yeah, yeah. Um, yeah, it seems like these any sort of like side effect that they potentially could, it's like in the news forefront really quickly. So that's good to know. So there is no risk of someone becoming blind. If anything, I would think it would be like going on these medications would cause the opposite. Like if you're overweight and have potentially diabetes, then going on these medications will decrease the risk of really anyone becoming blind. Um,
Well, just to be impartial, like to be fair. So if you have diabetes and you have underlying diabetic retinopathy, which is damage to the retina, and your sugars are really, really high, if we correct them too quickly, we definitely have a risk of worsening the retinopathy. And that can be permanent. So we have to lower blood sugars very slowly when the patient has severe diabetes. But yeah, mild diabetes where you're just preventing it from becoming severe, absolutely, or it's risk reduction taking place. But we have to, as endocrinologists, like if I have a patient whose sugars are in the 500s, I know how to get to the sugars to the 100s, which is normal quickly. But if they have underlying eye disease, I won't. I'll do it very,
yeah.
very slowly, intentionally.
Wow. Okay, cool. Didn't know that. That's awesome. Um, okay, so I think we answered most questions. May have missed a few, but in short, I just like want to say, Dr. Messer you have office in New York City and Connecticut
That's it for the moment. I'm working on Long Island.
and working on Long Island. And she has been prescribing these medications since 2006, which is super cool because most people I know just recently started using these meds and prescribing it. So it's been, you have a long history with them. And you're doing more than just with GLP-1s, but a full endocrinologist, and you have multiple other type of practitioners in your company, it's not just endocrinology. So like when you're going on these medications, it's so important to have many people be a part of your team to make sure that your weight loss journey is a successful one. Going on these medications just to figure out what dose to take and how to take it is never going to help you like long term. Having advice from someone who's familiar with these medications and also going to provide the right guidance and who else you should team up with, whether it's nutritionist, dietitian, psychiatrist, emotional eating therapist. There's so many other people that need to be involved in your care for people to have long-term results. And I think when people just kind of guess what dose to take and go too high, then I think that there is a lot of negative consequences that come with that. So thank you so much. Thank you so much for your time, and everyone could search you. We'll put your information in, and I appreciate having you here. I love talking to you about this, and I love that you use it for so many things also outside of weight loss.
Thanks, Baraka. This is
Thank you
great.
for your time. Thank you.
Have a good night.
Okay, bye.